It is my pleasure to be with you today and talk about the state of reform. We are deeply into this 5 years in my term, and I still feel like I'm running as fast as I can to keep the train on the tracks. This has been an incredible journey, and it's a journey that most of us have been on for a good number of years. And so as I reflected on the state of reform, where are we today? And listening to Greg and thinking about what you already know and what I could share with you that might prompt a nice conversation. I don't prefer to have speeches, and I don't think of myself as a speech giver, but I do want to share my perspective on where we are and then engage in a conversation with you so I can get a little feedback from DJ on your behalf, and if there's time for questions, so you can think about that. But when I came back into government 5 years ago, at the request of the governor, we were getting ready to implement the Affordable Care Act, as you'll recall, and many people ask why it has gone relatively well. Certainly we don't have a mission accomplished banner on our aircraft carrier, and there are lots of problems that we've encountered, but grading on the curve, we've done pretty well, given the challenges that other states have faced. And the first thing I say is because we didn't have the partisan divide in California. We had a Republican governor that not only embraced it in 2010, but actually had a version of it in 2007. So California was well familiar with the principles of what I often, in a friendly way, call Romney Care and then Schwarzenegger Care, and now it's Obamacare. But it was basically a market-based system that builds on the providers and plans and the program that we have, but with a notion of universal coverage. And so he embraced it. He established the legal framework for the exchange, and worked with the Obama administration to begin our march toward the Medicaid expansion with the low-income health program. So we inherited that and took that baton from the Schwarzenegger administration. Regrettably, we also took the baton of a $27 billion deficit. So the first 2 years of preparing this until we got to November of 2012, when we were able to get an endorsement from the people of California by their vote on Prop 30 to balance the budget, we were going forward on a conditional basis. We would implement the ACA if we could balance the budget. And that was hard and frustrating, but we did it, and we did it together with many of you in this room. So in 2013, as we really began to prepare for the first open enrollment period in October of that year, we were really on a fast track. We did it. We got our website up. We got nearly 1 million people enrolled in Covered California that first year, and over 4 million people in the Medicaid expansion. So we are way down the road of delivery reform. But this opportunity under the Affordable Care Act is so much more than coverage expansion, but the very expansion of coverage has created the framework for a lot of the other changes that I heard Peter Long talking about in the video, and that I speak with many of you about and we work toward, which is a fundamental change in the way not only we deliver health care, but that we think about health. Dr. Don Berwick, who was the head of the Centers for Medicare and Medicaid Services in DC at the beginning of this, coined what he calls, and now we all call, the triple aim: better health, better care, lower cost. And embedded in that is the notion that better health and better care are different things. And we've had a system over time of public health and healthcare delivery, and they were always intended tension, and sometimes at actual odds with each other over the amount of money that was spent and how much could be invested in prevention. And one of the things that I see as an outgrowth of all this is the coming together of our sense of health and health care. And as we change the financial incentives in the healthcare delivery to promote health, we're breaking down some of those barriers between people committed to public health and people committed to healthcare delivery, because we have to be, like I said a lot, the ranchers and the farmers must be friends. We're all doing the same work, and we have to do it without the rancor, and that has changed. In 2012, we established a task force in California called Let's Get Healthy, and set as a goal that we would be the healthiest state in the nation by 2012. We established 39 indicators, and not being a metric science person myself, I thought there were probably scores of things we could measure. It turned out there were thousands of things we could measure. We brought it down to 39, and among them are some that are healthcare delivery and some that are traditional public health, but they are married together in our work plan of 6 goals that many people throughout California have adopted and are incorporating. It has become the roadmap for our public health department, as well as our Department of Healthcare Services that administers the Medi-Cal program in California. We're also seeing dramatic changes in the incentives that have been created about systems of care. In the history of the last 50 years with Medicare and Medicaid, now 50 years old, and I'll say that when I worked in Brown 1.0, Medicare and Medicaid were only 9 years old in 1975, and we were already in our second generation of cost containment then. And cost then, healthcare in the 70s was about 5% of GDP. We all know now that it's north of 17%. And at each increment along the way, we all wring our hands and say it's unsustainable. But we keep sustaining it. We keep making it work. And in part because we're doing a lot more things for a lot more people with a lot more resources. But as we look to make it more efficient, again, as they commented in the video, we are trying to move from volume to value. And as we make those changes and we create payment systems, whether it's capitation, where you have a whole population that you're responsible for, or we have bundled services, or we have episodes of care, all of the accountable care organizations that are developing, what's at the heart of all of them is a patient-centered focus that I don't think has really ever existed in the development of our delivery system model. We are all patients, and many of us are providers at various times, but the things we get focused on are sometimes the business and the science and the practical aspects of doing our jobs. But if we really focus on the patient, it changes everything. And that's what I see happening in this reform movement. We are broadening our concept of networks. We're changing the way we think about systems where plans now have to compete on service and quality. One of the things that changed with the Affordable Care Act that is little understood is the impact of the elimination of underwriting on our plans. And where we see it most, and what is talked about, is the elimination of pre-existing conditions, that no one can be denied coverage. That was one of the main pillars of the Affordable Care Act. But the other side of that is that the plans have a medical loss ratio. They have to commit 80 or 85% of their premium value to the delivery of care. But the other part of the elimination of underwriting is that it dramatically changed the whole business model of the health plans so that they no longer are designing products on the basis of the relative health of the people they're selling their product to. They could eliminate people that were uninsurable when you had to get a physical to know whether you could have health insurance. But even within that, the products were designed on the basis of how healthy they were, and they were rated on that basis. And so one of the things, oddly, that I think was unfortunate about the advice that the president got when he said, if you like your plan, you can keep it, that was true in a very narrow context of the grandfathered plans where it was, but it certainly wasn't true of the overall delivery system, because this is changing the way everybody's plan operates, not just the people who are in the exchanges or who are in Medicaid. We are really moving to a system of organization that has never been possible. And so one of the things that I want to share is a little bit of the windshield on my vehicle here. What is the lens that I'm looking through as I evaluate programs and policies in this vast agency of health and human services, from child welfare or food stamps, SNAP, to child support payments, to aging, as Greg said. How do we look to rationalize this, what I think is quite irrational system? And the system, because it didn't have a concept of universal coverage, we developed one-off programs for the last 50 years. Special constituencies created special needs and got coverage or got programs or got services on the basis of a condition. So we have programs for maternity and breast cancer and HIV/AIDS and children's services, all carved out, as it were, related to the need that is being addressed. But if we could rationalize this system with the notion that everyone's going to have coverage, and that coverage is going to be comprehensive based on the essential health benefits requirements, and the benefit packages are going to be designed in a way that everybody can compare apples to apples, as we've tried to do on Covered California, then we could really get to a system of portability, and people would move across the spectrum. And my vision, the horizon that I see through the windshield of this vehicle, is Medi-Cal and Covered Cal and employer-sponsored insurance. And we would have plans that are working in all of those sectors. Medi-Cal plans, for example, historically we created special plans that would only serve the Medi-Cal population because there was a sense that the commercial plans wouldn't touch Medicaid. And we grew up with Medi-Cal plans. Now we have Medi-Cal plans that are offering product on the Covered California. I think there's a future where plans that have traditionally offered services to Medicaid populations may offer services to employers, where they can buy LA Care, for example, and get their services through the LA County health systems. The work that we did in the 2010 waiver to help the public health systems begin to prepare for the ACA and to prepare their delivery systems to be systems of care for the people that historically had been indigent and had nowhere to go except the county offices, would become a provider of choice and not just a provider of last resort. As this begins to change and we can have integrated systems across the lines, I think we have the possibility, if we have the vision, to think in terms of integration across all these sectors. But in each of these circumstances, we've got to break down some of the barriers and the way we have thought about it historically. And we have a lot invested in the system that exists, and that's why it is so hard to change. This is much bigger than an aircraft carrier. Turning it has been very difficult, but turn it indeed we have over the last 5 years. There are remarkable changes that I see every day in the conversations and relationships between plans and employers and purchasers, between purchasers and providers. I've got meetings all the time with labor union, trust fund administrators, together with large employers that come in and complain that the plans aren't driving a hard enough bargain with the providers. And the providers come in and say, we don't have enough money, we need to be paid more, and the plans are not reimbursing us our cost. And, by the way, I think that's one of the things that is changing away from cost-based services, which I say to my friends in the clinics. The federally qualified health plans have had a special place in this environment because they, like the public programs, were providing services that couldn't get care anywhere else. Once we have the portability of insurance coverage, we can move between. And so I'm seeing the community clinics doing extraordinarily innovative things in creating a system of care and a relationship with their patients that is very patient-focused. Again, once the attitude changes and we're not providing services to people who can't go anywhere else, we have to be customer-focused. So I think there is a lot of evidence in the marketplace that the marketplace itself is adapting to the changes that are required, and it's been hard to create patient engagement. I recently served on an activity that was sponsored by the Institute of Medicine to come up with national metrics after we chose our indicators in California on how we would measure our health. The Institute of Medicine convened a group to come up with, the report was just issued last year called Vital Signs, to come up with ways that we could put metrics around the triple aim. That was our charge. And very shortly into it, we spent a lot of time and a lot of discussion over whether it was a triple aim or a quadruple aim, because there's huge constituency around patient engagement. And patient engagement should be a part of the engagement. But patient engagement has been very difficult to do when the patients have paid so little for their care. They either paid everything and got no care, or they paid very little and didn't pay attention to the cost. So we're now in a new environment that was really made possible by the concept of universal coverage, where people will have insurance, and there's so much more work to do ahead to make this system more rational, that people, if they are going to California Health and Wellness or Shield or Kaiser, they will have a relationship with that plan that says, I know that plan is looking out for me, and they're going to find the care that I need through a system of care management. But to do that, then we've got to have the plans offering product across the whole spectrum. So that's very 30,000 feet. I know we're a long way from it, and we may never get there. But I think if in forums like this, bringing people together that are truly interested in the state of reform and how they can get past thinking parochially about how do I protect what I have and where I have been, into how can I serve this new environment? How can I succeed in a changed world? I often think about a group that I was involved in the 80s called Beyond War, and we used as a motto in that group a quote from Albert Einstein that said, after the development of the atomic bomb, that everything had changed save our way of thinking. And while I certainly don't compare the ACA to the atomic bomb, although some would, it is certainly true that everything has changed save our way of thinking. And I haven't given 1 ounce of thought or time to anything related to the repeal or even repeal and replace that gets talked about, because you're not putting this genie back in the bottle. It was built up for too long, the need for the kind of reform that the Affordable Care Act gave us the opportunity to do. And I'm very proud that we in California, not just we in government, but we in California throughout the delivery system, the consumer networks, all of the stakeholders have embraced as many parts of the Affordable Care Act as possible to make the future different than the past. And I am very thankful to groups like this that come together to talk to each other, to brainstorm, to share ideas and commitment to making lives better for our future Californians than they have been in the past. So, DJ, I'm very happy to have a conversation with you and with your audience, and look forward to the things that are on your mind this morning.
Wonderful. Let's give her a round of applause.